Good evening, everyone, and welcome to the webinar on the topic Role of CBCT Scan in Dental Practice and Oral Implantology, organized by the Alumni Association of Government Dental College and Hospital, Hyderabad. Now, I request the President of the Alumni Association of GDCH Hyderabad to present the welcome note. Sir, please.
Good evening. Once again, warm good evening to all present here. I welcome all of you to this webinar with keynote speaker from USA, Dr. Mel Mupparpu, alias Dr. Muralidhar Muppavarapu. Well, we joined together in Bachelor of Veterinary Science in 1978 in Tirupati, and both of us came back to Hyderabad and joined in BDS in 1978 in Usmania Medical College Dental Wing. And later he finished his, he is moved to Manipal to do his MDS in oral medicine, and later he left to Kingston, Jamaica in 1988 and stayed in Jamaica for nearly 6 years before migrating to USA. Welcome, my dear friend, for today's webinar. And all of our classmates are waiting to hear from you. And first of all, I must welcome our teacher's teacher, Dr. P. Ramchandra sir. Welcome, sir, for being here today. And it's an honor for all of us that you are present with us, amongst us, and gracing this occasion. I welcome you, sir. And I welcome today's moderators, Dr. Ramraju and Dr. Sri Krishna, and who also are the executive members of GDCH Alumni Association. And I welcome all the professors, heads of the departments, other staff members of GDCH. And today we already crossed more than 600 registrations, and that means it shows the importance of the speaker. And the topic today is very much useful for all the dentists and the practitioners. I'm sure it is going to help in our routine dental practice as well as on the research front, because most of the today's diagnostics are all mainly depending on the CBCT. And today's webinar is fifth in a row from the Alumni Association of Government Dental College and Hospital. And all these programs have been always successful with a minimum of 300 to 500 or above participation, which is an indication that all our members are very serious about these webinars. I welcome all the senior members, my teachers, senior faculty, junior faculty, practitioners, interns, postgraduates, and students, not only from Government Dental College and other dental colleges from in and around Hyderabad, but we have participation from all over India. And in fact, just now my classmate from Jammu said all his PGs are joining. And I also welcome overseas participants if there are any, because I can't see right now. And thanks to the scientific convener, Dr. Vivek and his team, who has been working hard to see that these programs run meticulously. And please join the webinar and enjoy the next 2 hours of listening from our speaker. Welcome once again. Thank you, one and all.
Thank you, sir. Now, I request Dr. Vivek Vardhan Reddy, sir, convener of the Scientific Committee of the Alumni Association of GDCH Hyderabad, to introduce the resource persons. Sir, please.
Thank you, Ram. Good evening to one and all. It's a pleasant task to introduce today's keynote speaker and both the moderators. Ram, can you please share the screen? Yeah. I think our president, Dr. Chandrasekhar, he couldn't resist introducing his own batchmate and dear friend, Dr. Murali, to all of you. Nevertheless, I would like to do it in a detailed manner. Dr. Murali was a house surgeon when I joined my first BDS, that was in 1983. Though there was a 5 years gap, he was always a mentor and a guide to all of us, and he used to inspire with his academic brilliance and friendship. He graduated BDS in 1983 from Government Dental College and Hospital, Hyderabad, which was affiliated to Osmania University those days. Then he moved to Manipal University, that is in Manipal, Mahe, which is known as Mahe now. He completed Masters in Oral and Medicine Radiology in year 1986. After serving as a faculty for some time, he moved to Jamaica, and from there he moved to one of the most prestigious Ivy League universities, that is University of Pennsylvania School of Dental Medicine, and completed his DMD in 1996. He took his certification in radiology from American Board of Oral and Maxillofacial Radiology in 1999. He taught as an assistant professor of radiology at UPenn School of Dental Medicine for 6 years, and then he moved to Rutgers School of Dental Medicine as an associate professor and director of radiology between 2002 to 2005. He was promoted as professor and director of radiology at Rutgers School of Dental Medicine, and he served there till 2011 before moving back to his alma mater, UPenn School of Dental Medicine, as professor and director of radiology, in which he is still continuing at the present. He received Master Educator Award, inducted to Masters Educator Guild of Rutgers in 2006, Fulbright Scholarship to the University of Malta, Credo in Action Award, highest award given to a faculty member at Rutgers in 2011, Senior Outstanding Teaching Award at UPenn in 2015, Basic Science Award at UPenn 2016, Outstanding Service to Students awarded by the student body of UPenn 2016. Not very easy to achieve, students judging their faculty members, and he was an outstanding service provided to the students. And later he was awarded Lindback Award for Outstanding Teaching again at UPenn in 2017. And recently, the most prestigious Alumni Award of Merit given by the university authorities for year 2021. Dr. Murli has more than 150 publications to his credit. He authored 7 book chapters and edited 2 books, and he has served as associate editor of DMFR Journal for 5 years between 2011 to 2016, has been serving as an associate editor of the prestigious Quintessence International Journal for the past 15 years. I thank Dr. Murli for his acceptance. I know how busy he was all these days, and he is very kind to share his knowledge and expertise in this field with all of us. Moving on to one of the moderators, Dr. Ramaraju, a very popular figure, liked by everybody in and out of Government Dental College. BDS finished from Government Dental College and Hospital in 1995. Then he continued with his master's in oral medicine and radiology, which he has completed in 2001 from GDC Hyderabad. He served in various institutions, and he is still honorary professor at SVS Institute of Dental Sciences, Mahbub Nagar. He is also the director of Rama Biosolutions Private Limited, founder of Curcuma Biosolutions. He served as business manager for Journal of Indian Academy of Oral Medicine and Radiology for 3 years between 14 to 17. He achieved a Young Researcher Award from IOMR for the year 2017, and he has over 30 publications in various national and international journals. Ramaraju presented several presentations, and he has filed for patents for intraoral topical application of curcumin, and also a patent on economical oral cancer screening device, Indian PCT, US and China. He has presented about this in various institutions, and he's been approved for funding by Department of Science and Technology under category of commercially viable academic projects, which is already approved by DCGI and CDS Co as non-invasive medical device. Presently working on identifying SNPs in various mucosal lesions and treating them with drug, which is identified as having more binding through drug docking along with natural compounds. Moving on to the second moderator, Dr. K. Sri Krishna, He finished BDS from Gulbarga University in 1996. Then he was a MDS student at Government Dental College Hospital between 1999 to 2002. Also has a PG diploma in Criminal Justice and Forensic Science, University of Hyderabad. Another very popular oral medicine and cardiology specialist in India, has over 18 years of teaching experience. Presently, he works as principal and also professor and HOD Department of OMR at Hazaribagh College of Dental Sciences, Jharkhand. He has served as executive committee member, editor-in-chief, and of Indian Academy of Oral Medicine and Radiology. Presently, he holds the post of treasurer of the same association. He was awarded 3 Best Paper Awards and 2 Best Poster Awards during the previous conferences, and he has published, he has contributed a book titled Synopsis of Dentistry, first edition, and he has more than 20 publications in index journals. Sri Krishna was part of the team of editors who published Souvenir during the Diamond Jubilee celebrations of our institution a couple of years back, and thank Sri Krishna for accepting the role of moderators for today's webinar. I complete the pleasant task of introducing today's keynote speaker and the moderators, and I welcome all the participants to enjoy the presentation of Dr. Muralidhar. Dr. Murali, over to you. Thank you.
Thank you so much, Vivek. Let me just thank you all for welcoming me to this nice event. It's always a pleasure to see friends and colleagues. It's even doubly a pleasure for me today to be able to at least share some of my experiences here for the last few years in oral medicine and radiology. And I'm honored that Dr. Ramachandra Reddy could make it, and many of my other professors could make it through this meeting. And I hope let's have a nice discussion so that it doesn't look like a monologue. It's more of a just learn through our conversations. Let me actually share my screen. Just a second. Okay. Hopefully you can all see my screen. Just make some adjustments. First of all, thank you for inviting me to this wonderful lecture series webinars. I would like to start with sharing my email first. It's a very short email to compensate for my long name. It's mmd@upenn.edu. So if you have any questions or doubts later on after the presentation, I would be thrilled to receive direct emails from you, and so that we can continue the conversation. The entire purpose of these webinars is not just a one-time come and go. It's just to cultivate our friendships even further so that we can learn from each other. And if there's anything I can do from my side, it's always my pleasure to share my knowledge with you all. I would like to dedicate this lecture to my late wife, who always inspired me, myself and my children, to be the best, to love one another unconditionally, and we miss her so much. I think she would have been really, really happy to be part of this, and I'm sure she's watching over. Now, coming to the topic of general, we have to go back to the years where we never had CBCT. The main topic of today's presentation is looking at the cone beam computer tomography scanning as a gift to all of us, so that we can actually see things that we couldn't see before three-dimensionally. But actually, we have to start from where we began very quickly without spending too much time, because most of you know exactly what I'm going to say, that two-dimensional radiography, what we used to call as a planar radiography, did not have the tools to look at the buccolingual dimension of any of the objects, or anterior posterior dimension of the objects that we look at, the structures in the maxillofacial region. So we had a limitation in general, whether it is cephalometric radiography, which still shows a lot of pathology. Like as you see on the left side, there was an antolith in the sphenoid sinus, which is an incredible finding. Calcification of the anterior longitudinal ligaments within the cervical spine, calcification of thyroid lamina. All these are incredibly important findings, but we can't go any further without having to show them three-dimensionally. And then we were at a period of time where everyone was scared about radiation in general, and we were trying to cut down the radiation dose. And if we take a look at the cephalometric radiograph on the right side, you'll notice there is a cap, leaded cap, which is called the cranial collimator, where people didn't want to radiate the brain while taking cephalometric radiographs. People didn't want to radiate the thyroid. We had the thyroid collars. On top of that, thyroid protectors like this CTP protector. So that was a time when we introduced cone beam computer tomography. So you can imagine the trepidation that people had looking at CBCT as something useful, something necessary, but also something that causes more radiation dose. That was the trepidation people had, and which is true. And then the next 20 years, CBCT came into existence in 2000, approximately around 99, 2000. I remember distinctly, I was at UPenn as an assistant professor, and we used to use a technology called as the movable table. It's a precursor to CBCT, and that's where patients used to stand in a machine, and they used to rotate instead of the machine rotating around them. It was a type of tomography, what most of us know as complex motion tomography. So from there, the CBCT came in. And obviously, the panoramic radiography was a big boost to all of us. It's been there since 1950s, 60s and 70s made a lot of progress. But there is an anatomical constraint. You can still see the maxilla and mandible, sometimes maxillary senses really well, mostly TMJs very well. It had good resolution, but not the best resolution. And it's still a 2D image. We all know that. The resolution of PANS were about 10 line pairs per millimeter. All the resolutions of the planar images are measured in LPPM, as you know. So it wasn't good enough. If you look at intraoral radiography, the resolution is about 25 line pairs per millimeter. So, believe it or not, this is the highest resolution of any radiograph in the field of dentistry and medicine completely together. Most of the medical radiographs are very low resolution, but they have high contrast, which we'll talk about in just a second. But just look at the anatomic resolution, or what we call pixel resolution. Radiographs are really, intraoral radiographs are really great, but obviously they didn't have the third dimension. So we couldn't use them for anything specific for, let's say, implant planning. They were actually good in showing anatomical deviations. For example, these two radiographs, radiographs of maxillary left premolar molar region show the extension of maxillary sinus, what we call alveolar extension, into the area where there was an extraction, prior extraction. Maybe it is on the buccal or lingual, we can't tell, but it seems to be pneumatized. And so that's important finding. So that could be easily found out by using radiographs like this. At the same time, this is the radiograph of maxillary right molar premolar region where it shows a residual cyst. And it almost looks like the previous one, but it's not the previous one because it's entirely different situation here. So all these are great, but in order to go further, to investigate this further, we didn't have any tools. And hence the third dimension was really important for us. And if you look at what we used to call as Kurban CT, because it was just colloquially called as, it shows everything. It's a Waters view. It's beautiful radiograph for showing the sinuses, especially the maxillary sinuses and all the other paranasal sinuses. But my gosh, look at the amount of complex anatomy it has. maxillofacial surgeons for years used all the PA views of the skull, Waters view of the skull, submental vertex, and other skull views for years before the 70s. I mean, in 70s, we had obviously CT scanning came into existence, and all these radiographs became obsolete. So back then we used to call it as a poor man's CT, because if you couldn't afford a CT scan, you at least have to order a PNS view or a Waters view. So these complex maxillofacial anatomy, which is compressed in 2D images, made us really, yearn for something more better, something more three-dimensional. So welcome to the age of CBCT. It's not a new technology anymore, because it's been 21 years since this technology came into existence. And we can take a look at, not only the axials, the sagittals, and the coronals, which have on the right side here. There's an axial view of the CT scan, it's a coronal view of the CT scan. There's a sagittal view of the CT scan. And we can also have a three-dimensional reconstruction, what we call simply in radiology as the recons. So in fact, all of them are recons, axial recon, coronal recon, sagittal recon, and a 3D recon, because they are not really a true representation of an image captured by the detector. As most of you know, and all of you know, because this is the thing that we learn in dental schools, that these are reconstructed by a computer program, an algorithm, and that actually displays these different views. So they're not really true images, they're reconstructed images. In addition to all these three recons, what we call as MPRs, multiplanar reconstructions, we also have, in addition to that, a panoramic reconstruction, which was unique, which was not a part of CT scanning in the medical world, because we use CT scans from the medical world, what we call MDCTs, or multi-detector CTs, or MSCTs, some people call it as, because it's multi-slice CT, but both are just regular CT scans. They did not have panoramic reconstruction. So it became an issue, because we as dentists are so used to seeing panoramics for years. And here we have three MPRs, which didn't have the panoramic reconstruction. So what the CBCT brought us, this technology brought us, is a way of reconstructing these pixels in a panoramic format. And then at any given point in time, in the space of that volume, we can do what are called orthogonal scans, like they go 90 degrees to that point of interest. So here you see this the three blue lines here on the right of the mandible. We are looking at a patient with suspected medication-associated osteonecrosis of the jaw, in short known as MRONJ. Many of us remember, those of us older, that we used to call it bronch many years ago, and bisphosphonate-associated osteonecrosis of the jaw. Then there came time where there were other drugs involved. There were anti-angiogenic drugs and everything else. And they said, you know what? It's not limited to bisphosphonates. Why should we call bronch? Then they started calling ARONJ, which stands for angiogenic drugs. And then it became even more widespread. I mean, they started looking at things with other medications, anti-neoplastics, things that are used for, like methotrexate-like drugs, anti-inflammatory drugs, and those kind of things. So then they started renaming as MRONJ, any medication associated with this necrosis of the jaw. So we have gone through 3 or 4 cycles of different, therapies and regimens, and now we have MRONJ here to stay. And every day, new drugs are being added that will either predispose or cause directly the necrosis of the jaws, especially in the mandible, and less likely in the maxilla. But it's seen in both the jaws with good frequencies. So that became a go-to technology for not only diagnosing pathology, but also going for implant planning. Every specialty in dentistry, without exception, use cone beam computed tomography now because over the years, in the last 20 years, if I had to sum up and say, what's the technological advancement that we made in the last 20 years that actually made CBCT safer is the technology of detectors. So as we went from the older CCDs and CCDs and CMOS detectors, we went into what are called solid state detectors, which not only cut down the radiation dose, they became more user friendly. And so today, the dose is so much lower compared to what I used in 2000 or in early 2000s. So, definitely that's one of the things patients like to know, because we cut down the dose from film to digital detectors in the last 20 years. Today, our dose is about a fifth or a fourth of the dose that we used to use for a full MOS series. So, which is good news for the patients. Now, the second thing, as you notice in the right side here, we have some soft tissue masses within the maxillary sinuses. And these masses, as we commonly call them as pseudocysts or mucus retention cysts in the maxillary sinuses, are pretty common. And we started noticing them more and more in frequency, and they became more of incidental findings since they don't really cause any harm to us. We don't even refer them to ENTs frequently unless it is associated with more exuberant maxillary sinusitis. But by themselves, they are just a secondary, reactionary formation to allergic reactions, or sometimes you see them more frequently in the US because a lot of people in the US are allergic to pollen. They have chronic allergies. And I think it's in increased frequency. In fact, there was some research done in Chevy Chase, Maryland here, where an endodontist, a good friend of mine, Marty, he actually did a research showing that during the times when pollen is high in the atmosphere, like in the air, like usually in the spring, that's when the pollen is very high in the US, in the Northeast US, there is increased prevalence of mucus cysts in the maxillary sinus. So that there is a correlation. So sometimes we learn with the correlative findings and then learn how to treat and manage these more commonly. I think most of you know this technology as its counterpart, MDCT. But for those of you just recently graduated or never been exposed to CBCT, it is just a simple explanation of differences between medical CT and the CBCT. So they all have these units called pixels, which are two-dimensional area measurements. And then if you make into a cube, which is a voxel, so voxel is a three-dimensional isotropic area within the detector, where the elements of image are captured in terms of the X-rays passing through and falling on a detector and converting into light, and the light is being captured as an area of intense light or less intense light. Now, a lot of these detectors are not really made for radiation directly. Radiation has to go through the patient's body, which is a must, because it has to penetrate the body, but it can't really form an image. For that, a lot of these detectors have what is called a scintillator. A scintillator is a converter. It's usually a phosphor, some kind of phosphor, microphosphors. It converts X-ray energy into light. And then light again is captured by these CCDs and CMOS. So eventually, whether you use radiation or not, you got to convert these X-rays into light. And the light is captured as an energy and then converted into a photon in the voxels that seen as an image wavefront. Now, the main difference between the CBCT and the MDCT is that CBCT uses a flat panel detector, as you can see on the right. MDCT uses a row of detectors. Usually, it's in a patient is in a donut. We call it donut because it looks like a donut, and it's an gantry. Scientific term is called gantry. So when patient is set in the gantry, as the patient moves, what we call the pitch, the X-ray beam goes on the patient in multiple slices, And today, with the 4th generation CT scanners, we take a continuous beam of energies and we get a CT scan, and it's sent to the processor, and then obviously a software converts them into the MPR images, which are axial, sagittal, and coronal images. Now, CBCT has an advantage over MDCT in that most of the CBCT images are isotropic. When I say isotropic, what I mean is the voxels that are what you see here, they're very symmetrical. So they're perfect cubes. When it's a perfect cube, you call that as an isotropic voxel. When it's not a perfect cube, you call it anisotropic voxel, which is MDCT. So in a way, our technology has prompted more accurate measurement of the anatomy, maxilla and mandible. So where does it come in help? It helps us in determining the actual dimensions without any distortions. So when you're actually doing an implant or looking at that mandibular canal proximity to a certain lesion, when you actually measure the distance from that to the area of interest, you're actually representing a true to scale. 1 millimeter is actually 1 millimeter. It's not 1.5 millimeter. There's no distortions involved. Whereas MDCT has some distortions. They make algorithms correct those distortions so that when the physicians, when radiologists make measurement, they are pretty good. But the technology itself is not very user friendly for measurements. So that's the chief difference. And CBCT has obviously a cone-shaped beam. So because we have a cone-shaped beam, we can capture the data very quickly. So we don't have to go through multiple passes. We go through one pass that is 360 degrees. We get about anywhere between 200 to 500 slices, depending on the thickness of slices that are predetermined by the resolutions. And then so the dose is lower. So the important thing we learn from this is we can use CBCT at a lower dose and get the same information as MDCT would do, except the fact that we don't have a soft tissue detail. Because for a soft tissue detail, we need to have a lot of dose. As the dose increases, soft tissue discrimination becomes more and more clearer. So unfortunately, we don't have soft tissue detail. But if you look at the kind of diagnostics we do, the kind of detail we want, it's mostly the bone. We deal with mostly calcified structures. We deal with teeth. We deal with alveolar bone. We deal with basal bone, mandibular maxilla, and we deal with maxillofacial structures. Now, if OMFS, an oral surgeon, wants to go further and detecting, let's say, a cancer spread, they would actually go and order an MDCT in the hospital with a contrast. And that's definitely an availability later on. But for us, for most of us who do skeletal imaging, I think CBCT is a great way to go with a low dose. And there are times where I also have an appointment at the hospital where I go as an attending at the University of Penn Hospital. When I'm there, when something comes like a suspected malignancy, I obviously order a medical CT with a contrast, because that's when I can have a better appreciation of the detail. And if you do a wide windows or narrow windows, you can be able to detect the pathology. But at the demo school, that's my main job, where we routinely take CBCTs when prescribed for either pre-implant evaluation or just demo pathology mostly. And in fact, we started teaching the CBCT technology to our first-year dental students. We call them freshmen. The freshman dental students they're part of their normal anatomy course. I have a slide later on. They start with gross anatomy, which is they do dissections. And then, in fact, they're all virtual now. In fact, pandemic has pushed us to completely remove the cadavers from the dissection halls now. So they are doing what's called an automatic table, where a digital cadaver is placed in a 6-foot screen table. The students come around and around the table, they dissect the body with their hands, like almost like a screen. And then they go through layer by layer. And, people ask me, like, is it really, it's a simulator basically. but is something that they would really go to the patient for the first time and touch the patient is disadvantageous. So, I would say that, well, about 10% of the students might become surgically oriented and become oral surgeons, or maybe a few more become implantologists. But those of them, they have to go back and relearn those things on real cadavers later on. But unfortunately, during the pandemic, every medical school in the United States, every dental school in the United States, they just stopped doing cadaver dissections. They've been repurposed, and they started buying these big anatomical tables. So all the dissections are virtual now. And then the class are on YouTubes, and individual lectures, like people like me go and lecture on a Zoom. They would just, that would be their anatomy lecture most of the time. So that's the state we are at this point. Now, one of the things that prompted CBCT to be more accurate is this particular algorithm. We call this Feldkamp algorithm. It's by three people, Feldkamp, Davis, and Kress, who are actually working for a company, GM, General Motors in Michigan, where they devised, they were not dentists, they were not even physicians. They were just trying to devise some kind of algorithm to reconstruct for car parts. And then we kind of adapted that technology that went into automobile engineering into dentistry and medicine, so that we now have a CBCT that reconstructs all the information that comes from patient's body into a flat panel detector at different angles. And then those angles are reconstructed as the CBCT volumes, which is incredible technology. And this is not something Dr. Hounsfield devised in 1970s when he was in England. His main research was focused on brain and 3D structures. And the way the images were captured were three-dimensionally. It's so much different than CBCT. So CBCT is almost a revolution when it came in 2000. Now, all of you know that there are three different volumes that we capture. A small volume is usually about 4 to 5 millimeters times 4 to 5 millimeters. Medium volume is usually about 8 by 8 centimeters or 10 by 10 centimeters, which is good for most of us doing implants or maxillofacial prosthesis or anything related to the dentistry or teeth. If you go maxillofacial like surgery, obviously you need a larger volumes. If you're an orthodontist or a prosthodontist who are reconstructing like condyles, reconstructing the floor of the orbit, or just want to look at the sella turcica, then you would need a large volume. And there are different large volumes. And most of the large volumes end just above the sella turcica, because we don't need to go up to the top of the calvarium. It's not necessary most of the time because it doesn't give you information. And also in the US, the medical liability is so high that if you take a volume, you must be able to interpret those volumes. Otherwise, get it interpreted by somebody else who creates a radiology report. If you don't have that, you're sitting on a liability that somebody can sue you at some point in life, and it's a scary thing. And so people generally take smaller volumes, what they really want. People take medium volumes if they can read the medium volumes. And the specialty of oral medicine radiology is so small compared to the population of the United States and the number of dental schools here. It's almost impractical to be able to serve the entire dentistry profession by just being us the only radiologists in the country. So it is almost impossible. So the American Dental Association many years ago started asking the American Academy of Oral Medicine and Radiology, saying that how can we train general dentists in making them more aware of the maxillofacial anatomy via radiographs, via CBCT technology. So with that prompted most of the dental schools changing their curriculum, and then actually started teaching three-dimensional anatomy from the first year, from the get-go. Because if you teach dental students 2D anatomy from the get-go, and then by the time they become practitioners, they would not imagine the anatomy as three-dimensional. They would only have a 2D anatomy in their mind. So that's the reason we started teaching. I started teaching I was really glad that students really quickly started learning. Within a matter of days, they were very enthusiastic. They started looking at patient body as a three-dimensional anatomy, not a 2D flat panel anatomy. And so I think I'm excited that I will continue this journey. It's a good thing to do because when they get out of the dental schools, they can obviously interpret their own radiographs. If they need something complex cases, they can always come to us. But for majority of the cases, they don't need. They need to be trained, and that's self-sustaining modality. Now, there was also a question in Q&A ahead of time that someone asked me, what's a dentist scan and how is it different from a regular CBCT or CT scan? Now, dentist scan was a medical MDCT, essentially MDCT, processed through a software called dentist scan. Now, medical scan, as I told you before, it never had the capability of producing panoramic radiographs or reconstructions. This one had. So fortunately, I was able to use this dentist scan just before CBCTs came available for a few years, basically. But what happened was that dentist scan, the company was bought out by General Electric company, GE company, and then killed it. Because GE was investing on CT scanners and CBCT scanners. They didn't want this technology to be there, so the people don't buy CBCT scanners. There's a little bit of a game they played, and then they bought the company, and then they closed the company. So those of us who were there at the time were able to use this technology. So the technology is very simple. It's just regular MDCT images. If you take a look at those scans, they are not as clear as they would be as a CBCT because the resolutions were not as high. Now, believe it or not, many of us know this fact. For those of you who don't know this fact, if you compare the resolutions of intraoral radiographs, IOPAs versus Bipings, there were 25 line pairs per millimeter. Let's actually use that algorithm, compare it to what is the line pairs here we're talking about. From 25 line pairs, they become 10 line pairs in a panoramic radiograph, which is half the resolution. So that's why the pains are not really the great, OPGs are not really great to look at some fine detail. For example, the canals in a molar or premolar, or that real PDL changes or laminar dura changes, very, very small. Now, if you come from panoramic radiograph to a CBCT or a CT, the resolution becomes about 5 line pairs. 5 line pairs. So they look blurry. If you enlarge them, they look even more blurry because they're only 5 line pairs as opposed to 20 line pairs and 10 line pairs. So dental radiographs are really, really high resolution anatomically. But the issue comes where is the contrast. If there's a disease, if there is a lymph node that is necrotic, what you must do is that use a contrast that is highly differentiating. And that contrast is given by MDCT and also CBCT. So even though their resolutions are really low in terms of what we call anatomic resolution or pixel resolution, they're very high in terms of contrast resolution. So we take contrast to give up a little bit of the line pair resolution with the CBCT. And that's the technology. So technology became outdated. Now CBCT became more of a in technology at this point. So again, just coming briefly into the teaching of CBCT to dental students, I think we must all do this as part of our training the next generation of students, not only to what we call pre-doctoral program. In the US, there is no bachelor's degree, it's a doctoral degree. So instead of calling us undergrads, we call them as pre-doctoral students because they get doctorate degree at the end of their dental school. And then pre-doctoral program, we introduced CBCT into gross anatomy. Gross anatomy is basically general anatomy. Basically they do dissections of the entire body. All dental schools now, they just don't limit themselves to head and neck. They do whole body. In fact, in places like Harvard, dental school and medical school are combined for the first 2 years. They go to the same classes, they attend the same lectures for the first 2 years. After the first 2 years, when they become third year, dental school students come to dental school, medical students go to hospital. So that's the trend nowadays because it becomes easier to teach anatomy and then they can go into specialties OMFS, they can easily go into, again, med schools, and then they don't have to do the anatomy and physiology. So the advanced standing OMS MD programs are only 2 years, so they already done the 2 years. So we teach osteology, and then I go after osteology taught by anatomists. I teach radiographic anatomy. Then there's bone morphology, where we talk about bone mineral densities, how the bone changes over a period of time as a person grows from young adult to an old person, and then beyond, and the development of osteoporosis, the development of osteopenia, all those things. And then in the second year, they attend the general and oral path classes, where we teach all the diseases that we can get in the same thing that we taught them ahead of time in 2D imaging into 3D imaging. In fact, what I do nowadays is I do combine them together. I show them a radiograph, 2D radiograph, immediately show them a 3D radiograph, so that they can understand the difference in the visual pathology. Then all dental specialties will get the training as part of their first year PGY. PGY once is a 2-year program most of the time. Sometimes they're 3-year programs. And there are 6-year programs in maxillofacial surgery. And there are 4-year programs that are combined dual specialties, like perio and ortho is combined to a specialty in the US for the graduate programs. Perio and endo is combined. And there is ortho and perio are combined. So there are different combination specialties, which is good because it takes 2 more years, but you don't have to really worry about that other part that you deal with every day. If you're an orthodontist, perio is very important for you. If you're a prosthodontist, perio is important for you as well. So, and also the other way I started teaching anatomy to the dental students is by the numbering system. So I have the entire head and neck, whatever I can teach is numbered in anatomical areas. And definitely when, instead of putting arrows, instead of putting different things on the radiograph, just put a small number. And I can say number 5 is always clivus, and 5 remains clivus as many times as it can show the anatomy. And 16 remains as your area where basically the spinal cord passes through. It's the number 15 is the spinal cord, and the 6 is the odontoid process. Number 3 is the sphenoid sinus. So the foramen magnum actually is not represented completely, but 16 is just part of that foramen magnum. And then 6, 9, and 10 are the vertebrae, C2, C3, and C4. It becomes very easy for me to teach this anatomy this way. So I can, every time I teach students, I'll go back to the same numbers. That's one way of teaching. And obviously, I think we all have our own ways of teaching, but I just found it very incredibly helpful. This is actually part of my textbook, which was published a couple of years ago. And I started doing that even in the textbooks. So anatomy becomes very important for both maxilla and mandible, and CBCT can show incredible detail, the orbits, the sinuses, the ostia. The nasal anatomy becomes really, really incredibly detailed. And as part of my job, I have to report on both maxillofacial and including nasal anatomy. That includes DNS, includes the conchae, includes the turbinates, any deviations of the ostium, the uncinate process, and a lot of them to deal with maxillary sinus anatomy itself. And when there is a blockage of the ostium, that's important. So I can refer them to OMFS or ENT, depending on the symptoms and depending on what the treatment outcomes are. And so the larger the volume we have, the more we have to diagnose, the more we have to detail and then make a report of that. And then back in the day when we had PANS and our PAs and everything, we never had the detail of the anatomy of the neurological detail. We can see every single, the anterior posterior alveolar nerves, the middle superior nerve, the posterior superior, and all these nerve canals are seen with incredible detail. And for a good reason, because if you're placing implants in these areas, you must be able to isolate these and not to injure those neurological, neurovascular bundles. It's not a big problem in maxilla because the numbness is not all that severe if there is an injury to the nerve. But in the mandible, it becomes really, really important. Now, medical legally, in the United States, I've been to 5 or 6 court cases so far as an expert witness. As long as there is no neurological deficit, the jury are kind to you most of the time, to the dentist, to the person who did the surgery. If there is any sign of neurological deficit, in other words, if there is any numbness, it's considered a major, major blow to the case. So if you're doing a third molar extraction, if you didn't take a CBCT ahead of time and you by chance injure the nerve and cause significant paresthesia, even if it's for a few months, then that few months will become a problem because patients can go and actually complain to the dental boards that you did not do the standard of care. They can actually sue you and for numbness and if the jury is very quickly acted upon, and they can give the patient millions of dollars. In other words, you lose a lot of things. Obviously you're all insured and the insurance companies will pay up. But the problem is we should not take the chance. When there is technology available, we should be able to scan them. So now the standard of care for even a single implant is a CBCT. You must take a CBCT and then display it, even a small volume. And the standard of care is defined as something that's available locally, something that patients can afford, something that you should interpret. 20 years ago, I would have said different. I would have said, no, this is not standard of care. Today, for what we know and the availability of CT scanners around, it is standard of care. And it's time that all of us know everything about the technology and how to interpret radiographs properly so that they don't become an obstacle for our progress. Now, here is another good way to show anatomical deviations in some pathology as well, because some of these pathology stays and then patients don't even know about it. For example, there's an antolith here, which patients will have no idea that it was there. A maxillary sinus pseudocyst was there, asymptomatic. Patients don't have any idea that it's there, but they're probably having some pollen allergy. And then it sits and it kind of goes away after some time. Now the question here is another mucus retention cyst. Now on the top left here is a classic case of maxillary sinus. It's sinusitis. Now how can I tell it's a sinusitis versus just a mucus thickening or mucositis? Is because two things. One is in every case of maxillary sinusitis, whether it's acute or chronic, there is what is called as air fluid levels. So if you take a look at this, there is a concavity here. And that concavity means that anytime patient breathes in air, it's a fluid, and fluid conforms to the air that is pushed inside and before it goes outside. And on top of that, we take a look at that, there is the air bubbles here. These air bubbles show that it's probably bacterial infection, and then bacteria have the ability to actually create gas bubbles within the area. So it's most likely a maxillary sinusitis. I said most likely because sometimes we could be wrong. And then most likely it's a bacterial infection. And then so we obviously send this patient to either OMFS or an ENT, depending on who is available on that particular hospital. So these are the ones treated, managed with antibiotics, with other things. But if you ask me the difference between this and then the one which is mucus cyst of no consequence. If you're doing a sinus lift there, when somebody asked me, said, Dr. M, are you willing to let this go? I said, yeah, because you can do a sinus lift there easily, as long as you don't puncture the membrane. So it stays above the membrane. It probably goes out just a bag of water, mucus. Whereas here, obviously, I have to treat the patient with antibiotics and let it completely heal before you do any sinus lift. So that's the big difference between identifying the mucus cysts or mucositis or polyps versus significant, maxillary sinusitis. And so there was also another question about someone wanted to know, how do we interpret this CBCT volumetric data? How do we report findings? Well, many years ago, I was looking for the same answers myself, even though I interpret radiographs. I never saw any paper published. So we actually looked at Dr. Singler, myself, and Dr. Priyanka. They published this paper in late 2000s. So this would be something that we all can use. It's in quintessence. And I'm glad to send, I have the full paper with me. I can send to those who really want it. And this should be something that I do routinely. What we do is We take a look at the whole volume. We start with these MIPs, maximum intensity projections, which are essentially they are 2D images, 2D snapshots of 3D anatomy. The reason they are important because it will give you the calcifications very quickly. You give up the calcifications. There's a calcification here in this region, how these will know. Unfortunately, this patient kept the earrings, which the foreign technician, you should never do that. You should never keep any metallic rings that they become artifacts. And unfortunately, sometimes people forget to remove them or don't tell the operator. If there was a calcified carotid here, if there was a calcification lymph node, I would catch it in just a second. That's the reason MIPs are the first go-to images in my interpretation. Then the pan reconstruction. And as we talked about it, how this is the ideal reconstruction. We do a pan recon, and here it shows a large, actually 2 or 3 coalescent mucous cysts in the right maxillary sinus. And left maxillary sinus seem to be within normal limits. And obviously, the rest of the things are, we know that it's just part of normal anatomy. The axial slices are important as part of what are called the MP or multi-planar reconstructions. You can see an axially, and obviously, depending on the slices that we get, we can see either 1 millimeter cuts, 2 millimeter cuts, or even further. The smallest cut you can make, the thinnest cut you can make, is the size of the resolution. And by that, what I mean is, let's say if you're looking at a 200 pixel resolution, a 200 voxel resolution, that's the thinnest cut you can go to. It's called native resolution. So I'll show you some cases where the native resolution is shown up. The sagittal slice, again, it's a section taken, where the anatomy is divided into left and right halves. We go from right to left to right. And then we document the technology. This is a oblique sagittal slice showing, I think, probably right maxillary sinus. Unless we have a markings, we won't know right or left, unless we see all three in one different plane. It shows the 2 coalesced mucous retention cells, which are, again, very benign, very normal. Again, this is a coronal view showing the right and left slices. Right maxillary sinus, left maxillary sinus, and all the nasal anatomy shown here. Then the same mucus are noticed here as well. And so that's how we start looking at them. Look through every single slice, every single format, all 3 reconstructions, including 3D recons. Then, and again, this is a demo school, so we have forms created by me and forms created by the IT department, where we start with the description first. We go on to different findings, and then all the findings are already categorically mentioned in the system there. And then we look at either normality or look at either these changes. I also have a digital editable image where we actually draw things on. And that would help us to know the bone levels, to the periapical status, missing teeth. But just for our scrapbook, you can have a scrapbook of sorts. And then it's part of what we call the RADCON form. RADCON is short for radiology concept form. And then we can look at other things, including details like osteoportification, calculus, bone loss. And then there's generalized bone loss. It gives some pop outs saying whether mild or moderate or severe, horizontal versus vertical. And then we also give this question, it's an important part of what do the future examinations consist of? You're going to tell the patient that, hey, based on what you have today, I think you might need some selected PAs as needed at some point in time. It's not a specific for certain recommendations like, oh, you need to buy things in 2 years, you need to buy things in 6 months. We don't no longer have that recommendations anymore. We went away from that long back. It's because we figured that people's need, they change, their needs change. Patients have different needs. Today, the patient comes with 5 teeth. Tomorrow, there might be 1 tooth or none. So then if I recommend something to the patient that you need x-rays of all these teeth, and next time the patient comes in, there's no need. So my recommendation is bad now. So I think we went away from that. I just started saying that you selected PAs as needed, bite-wings as needed, based on your caries prevalence and things like that. And if you need a CBCT, we have to prescribe here what kind of volume we need. Limited volume of a specific area, right? Manual, for example, it's a prescription. All radiographs are by prescription only. So naturally, we had to prescribe them and not just tell the patient to get X-rays. It's a part of, and then if you look at the CBCT report here, and then I go into details like, for example, all the mandibular anatomy, maxillary anatomy, sinuses, osteomineral complex, TMJ area, airways, cervical spine, and skull base and intracranial findings, if any. And if they're not, just say that I usually look for things like the stereo fossa, maxillary fissures, and if I can, I look at the foramen from the valley, spinal muscle, the patent, and median nerve is very important for us as dentists, because median nerve connects the infratemporal fossa through pterygopalatine fossa into the brain. So in other words, it's actually a pathway to the transmission of either malignant changes into the brain or even inflammatory changes, like in some things with infections. And then I start writing impressions and recommendations based on that. So this is a typical format I use for reporting. And people have different reporting formats. And some people actually start putting images into their reporting formats, which I don't personally like, because none of the medical reports come with images. You can get a CD if you want to, but I don't want to copy and paste images that may not represent the entire pathology. And so I don't want to be limited to one little slice that may not show the entire pathology. Now, at the dental school, we use a PAC system. I think most of us do in different parts of the world, including your dental schools where you are, or in the practice where you are. There could be small packs, mini packs, or could be a large pack system. Pack system actually takes away all the headaches of storing data into one particular computer, and it stores into cloud. It stores into servers that are no longer be part of your clinic. And then you can on demand retrieve them from different locations. So here, for example, these are all the locations where in dental school we take x-rays. They're displayed directly in the terminals in the dental school, what are called the soft terminals. By the same time, they're also captured into the central data archiving system, where these terminals, if you log off and log on, you can query, and then you can get the data back. So it's a very safe system. And I think I really enjoy working on a cloud platforms, working on my packs. You don't never lose any data. Data is always there. It's given back on demand. So this is a part of a cartoon I created as for my textbook, which is coming out in June. So we have MyPacs, that is the company that we use, the dental school, and we not only store CBCT data, we store all the other data, panoramics, cyclometrics. Currently, we have 9 CBCT scanners in dental school, and all the 9 CBCT scanners are streamlined into one PAC server, and from there we get the data back. Along with it, we also store our intraorals, bite wings, panoramics, and cyclometrics, and all other PAs, pulse, and everything else. Then there was this question of what is the effect of pixel resolutions on image appearance? It's an important question. And I'm going to show you maxillary left first molar, which in the US we call it number 14, but actually is I think 26 in the other systems, but universal system is number 14. So if we take a look at the 14 at 16 millimeters of resolution, and you didn't see much. There was just a faint halo. I'm saying that there is probably some periapical radiolucency, maybe it's healing because it has a status post endo. And when you look at a 12 millimeter thickness, there is something more now. If you look at 8.3 millimeters, it's even more. And as you go into 4 millimeters, it is incredibly larger apical lytic radiolucency in relation to the mesial buccal root of number 14. And then if you go even further, 750 microns, it's even worse. And I think we went up to 250 microns, and then you can see that there is some mucositis over the maxillary sinus, a large lytic radiolucency, and then the lucency also extends into the middle of the root as well. Maybe there is dislocation, bone loss as well. So this is incredibly different information at this resolution compared to a 16 millimeter resolution. So what you miss is when you use a panoramics and other radiographs, this is what you miss. You don't have the exact the periapical lesions depicted, and also take a look at the bone loss in between those two here. There is some horizontal bone loss and probably even beginnings of the vertical pocket. So this is what the detail that you would get at higher resolutions. When you scan patient's anatomy, try and scan to the best possible resolution, depending on the task. If your task is just a bone evaluation, and then it doesn't really matter. You can take at a maybe 200 microns or 300 microns. But if your task is endodontic tasks, if your task is to look at the canals, lateral canals, missed canals, then you have to go at the highest resolution. Typically, it's less than 100 microns. At 250, you can see so well. You can see the canals as well. But if you go at 200 microns and below, and some of the machines now are capable of scanning at 80 microns now, like J Morita, CareStream, and Plan Mecca. Some of these companies have CBCTs. They scan at incredibly high resolutions. And so that would be the goal. And then if you look at this ideal CBCT specs for endo CBCT, 80 is what is recommended. Unfortunately, as you go down the higher resolution path, you also get a lot of noise. And noise is something that unnecessary information that is there. And then because now at that resolution, it detects every little beam that is available for the detector. And that is sometimes becomes a headache. So I think we have to be careful in not choosing that particular resolution every time you look at a patient. It's task-based. And the volume, the smaller the volume, the better for us to focus on an area of interest. And again, it's another example to show that. So as resolution changes, you can actually start looking at things really, really better. At 10 millimeter, there was nothing. At 5 millimeters, there was a beginnings of pathology. And at 2 millimeters, or even less than 2 millimeters, you can see a large, perhaps a single cyst. Again, it depends on symptoms. It could be a scar, it could be a residual cyst. It all depends on what the patients show up with. And then there are things to see. The value of CBCT is incredibly high in terms of showing anatomical detail. And here is in this particular CT scan, it's an 8x8, it's a medium volume CT scan that is displayed in MPR. It's the axial view here, sagittal view, and coronal view here. See how beautifully the palatal tori are displayed very nicely. And there's not much space, and this patient comes to you for a removable partial denture, and then we can't do it. Patient comes for even implants, but be very careful as to what to do with this exhaustosis. So this is torus palatinus, this is torus maxillaris, like we have torus mandibularis. They're all Latin words for palatal torus and maxillary torus and mandibular torus. And they just look fancy when you talk to the patient that you have torus palatinus versus saying that you have bone, extra bone. So sometimes we just get a laughs and giggles out of that and naming the Latin words. And then when you see mucositis, the maxillary sinus mucositis, see back in the day, I used to call it mucus thickening. Before, then the students start asking me, so what's the difference between mucus thickening and mucositis? Isn't mucus thickening an inflammatory process? Then I say, yeah, they're right, absolutely. You learn things as you go along. So I deleted the word mucus thickening from my dictionary and then said, okay, it's mucositis, definitely. It could be mild, moderate, or severe. Now you can catch those things in intraoral radiographs, but the gold standard for that is always CT scan. And CT is the gold standard for maxillary sinus disease in general. So if you go to an ENT or OMFS, the first thing they want is a CT scan because they don't want to leave anything for chance. Especially, it's a very litigious society that we live in the US and even in England, I think, even India also, I think they start catching up and start suing people. So you don't want to just, I understand that radiation dose is higher and most people understand that, but what is more relevant is diagnosing the case is more relevant. So occasionally that you might have to call that shot and say, well, I need to go for CT scan, it's only because you don't want to miss those significant mucositis or maxillary sinusitis, or God forbid, pan-sinusitis. It's sinusitis and everything else, including your sphenoid, ethmoid, frontal, and maxillary sinuses. So it's really important for us to catch that. And then here is the orange arrow shows the maxillary sinusitis, because we talked about the mucosa being not, it's mostly water, air fluid levels showing up as a concavity. And then the black arrow shows the antolith. Antoliths are calcified mucous plugs that are stay within the mucositis. They don't do anything, they just do very harmless. So I think we can just look at them as incidental findings and we report them to the referring doctors. And then we just don't do much about that. And then another a very contentious topic in CBCT technology that brought us is the measurement of airway on patients before and after treatments, and then trying to identify patients with sleep apnea. It's a very contentious topic, only because it has got solid evidence. We can do that. The issue is that when we scan patients, most of the time, there's only one scanner. It's called Newton scanner that actually scans the patient in the supine position. But most of the scanners, 99% of them, scan the patient in vertical position, either stand up or sit down. Patient's head is vertically placed, oriented. Now, even with the worst of the worst sleep apneics, when they're sitting up like this, they breathe normally, somewhat normally, right? So what are we going to achieve? That we are not able to demonstrate sleep apnea in a patient who is sitting up like this and conscious and be able to breathe normally. Your airway is going to be somewhat patent, no matter what. So the being a devil's advocate is that how do we get these patients diagnosed? Okay, the patients have symptoms of sleep apnea, obviously. You can take a CBCT to identify the probably reduced or narrowing of the airway, pharyngeal airway, but the definitive diagnosis is always in the sleep study. Patient has to go to the hospital, has to go to the admitted, and then they do overnight sleep studies, the somnambulic studies. And then that's when patients are deep sleep, semi-conscious sleep, deep sleeps, that's when the airway gets obstructed. And then the other part of it is the uvula, the soft palate uvula. There are OMFS surgeons who actually try to, that's actually part of the treatment they do, first treatment. If there's a large hyperplastic uvula, they do uvulectomy. Uvulectomy is one of the treatments that are, especially if uvula is contributing to the factor. So that we can diagnose easily because you can see the uvula very clearly in this region, just attached to the soft palate. And then, so if uvula is really, really big, it actually takes part of the airway space, and then that could be a problem for the patient. And then those patients are typically snore a lot. So there are oral surgeons who here in US, in Philadelphia especially, I know one doctor, they call him as the snore doc because he actually treats the snoring because he actually does uvulectomy routinely. And that's an important part of the treatment too. But giving a diagnosis of sleep apnea purely based on the CBCT technology is not really good because there might be implications in future. You might be called in a medical legal case. Then they'll ask, how do you diagnose the sleep apnea based on CBCT in a supine and standing position versus standing positions? And so I don't normally, there are a lot of practitioners who ask me all the time, can you be our CBCT guy to diagnose sleep apnea? I say, I'm sorry, I'm not your guy because I don't want to go into that contentious field. I definitely do segmentations. I know how to do measuring airways. And the second thing, most important thing is we don't have a definitive way of identifying how far we go up. Where is the cutoff for your nasopharynx? Where's the cutoff for your oropharynx? So is this volume mean anything to us? Somebody goes and measures the volume up to here. Is that better than us? So all these irregular and undefined areas are there, which no one has really defined what is the total airway that you're measuring. And that's the reason I think I don't go into that. And I do measure airways, and I report them as just incidental areas. So there are different softwares available. This is taken with ICAT, and this is taken with another software. I think it's Dolphin. And most orthodontists, if you see publication AGO DIVO, which is the orthodontic journal, then they use Dolphin. And Dolphin has a way of doing. So again, what's the difference between this airway and the airway here? They're totally worlds apart. Can you compare them both? You can't. So I can't compare a patient A to patient B, taken with two different softwares and two different measurements are procured. So it's really difficult to judge that thing. But let's say if you're doing a maxillary osteotomy or mandibular osteotomy, definitely makes sense to do airway measurement before and after, because you can actually show significant change in the volume. That's all it is. It's nothing to do with sleep apnea, just airway change. The anatomical area is clear. Maybe if you do an advancement of the mandible, that was actually causing the issue of somewhat of a lowered sleep, maybe sleep apnea, but not definitely sleep apnea that we see in the hospitals. That would be something that we can demonstrate, but I would not go in anything beyond that. Now, recently I started doing segmentation of the nasal airways, only because my belief is that if you don't segment nasal airway and use only the pharyngeal airway, you're only missing part of the nasal anatomy. So my goal is at some point to be able to prove that nasal airways and pharyngeal airways are contiguous structures. And if you're measuring the airways, you should measure the airways continuously. Because somebody has a blockage of airway breathing mechanism, and it could be blocked because of nasal passages. And without knowing the anatomy of the nasal airway, you really can't diagnose anything in terms of the blockages. So I think we recently wrote a paper that we started segmenting for volumetric assessment of nasal airway. Nothing to do with CBCT, but it could be something that precursor for CBCT that could be quantified by looking at the anatomy before and after, especially doing some ENT surgeries or maxillofacial surgeries. It's just another way of documenting that your surgery is successful. Pre-orthodontically, CBCT has been used routinely. And here you can see the impact of canines with a large follicular space bilaterally and trying to resolve these lateral roots. And that's one of the significant findings that you always look for, that you don't want any resorption of the roots of the lateral incisors. And if they're happening, immediately go in, that's the time to intervene and then expose those canines, folliculate them. And at this point, they're probably considered integerous cysts, because anything more than a few millimeters diameter in follicle enlargement, as we all know, it becomes an integerous cyst unless proven otherwise. It's also used for diagnosis of a lot of TMJ-related diseases. And I happened to see a case, a 14-year-old girl came to us, referred from hospital, actually from an orthodontist. And then she presented the day she presented to me. I was doing CBCT. She said there were some issues that her physician was concerned about, and then her right radius ulna is slightly underdeveloped versus the left radius ulna. This is a normal hand, and right hand is slightly smaller comparatively. And then when I took a CBCT for her, she was having braces, so there was some issue with metallic artifacts, but we would clean it up a little bit. Note the anterior open bite, significant, and she never had it before. When she started the orthodontic treatment, she never had an anterior open bite, but she developed along the process. Then when I looked at her TMJs, right and left TMJs, there was significant flattening and arthritic changes almost consistent with the rheumatoid arthritis, RA. She never had RA. She got RA worked up. There was RA effect was not positive, and she only had increasingly progressive anterior open bite. And so, to make a long story short, when I went back and looked at the patient and we talked to the doctors, and we had a conference with the orthopedists, then we looked together. The diagnosis was what's called as the Maid-Lungs disorder. It's a rare disorder where it affects the proximal end of the radius and ulna, and they're hypoplastic, they're not developed well. And these patients may have, it's only a chance that they might have TMJ involvement. This is actually the first case reported, and I couldn't publish it because patient's mother didn't want to publish it. She didn't give permission for me to publish it. Probably the first case of a reported mid-lungs disorder with definitive changes of the TMJ condylar changes. Until then, there was only in the chat rooms and patient forums, patients say, well, my daughter had TMJ issues, but no one knows what's happening. And then sometimes you stumble onto these kind of things, incredible findings that I was surprised that we were able to find this patient like this. Hopefully one day we'll publish it if patient mother permits, but that's a change that we noticed. And we also started doing research of late, merging the PET scans with CBCTs. It's only on a limited basis, obviously, because patients have agreed for these things to come back for another CT scan, CBCT, on top of their original CT scan that is done in the hospital right away. Then here is the patient with significant findings in the soft palate. In fact, they were looking for metastatic areas, and she had a metastatic breast carcinoma, breast CA. She was followed up, and then she had some issue in the soft palate, and she had issue with swallowing. And then when we actually fused the sodium fluoride PET as opposed to FDG PET with CBCT, we're able to find exactly the same thing that MDCTs would find. So another area of research is that can we use CBCTs in lowering the dose for the patient after patient obviously comes to PET scanning. So it's a process that we have to go through with the hospitals, and we tell the hospital that how CBCT is a lower dose, and then MDCT is higher dose. Already they're getting large dose because they're having a radionuclide injected into the body, and that radiates the body itself. On top of that, to marry the CBCT and PET scan for merging purposes, they take another CT scan. It's called PET CT. So PET CBCT is something that comes along. Endodontically, I'm going to go a little bit in a few minutes. We'll try to, because it's after 7:20. So I'm sorry if I'm taking too much time. Endodontically speaking, you can obviously diagnose these as dents and dentae. You can see the root morphology of teeth. You can diagnose missed canals. This is a classic case of a DB2 for tooth number 47. Now, you don't have normally DB2s. It's mostly MB2, MB2s are common, but occasionally you have DB2s as well. And this is the case of Dr. Setzer, Frank Setzer, who is my colleague mentor. He came in this case where there was obviously a pre-op that was missed canal due to retreatment, and then it was retreated again with a larger master cone and 2 canals. Now this time they used a microscope as well as a CBCT this time. These are just PAs, but CBCT was used to identify this missed canal. And then 6 months follow-up was really good. Now, amazing type of, the canal morphology is incredibly complicated, as we all know. And then we negotiate those canals with CBCT. There's a case of internal absorption, history of trauma, and obviously it was treated well, and including the absorptions that were treated. Tooth number 3, again, there was a missed canal, a large lesion both in MB and DB, and it was treated well as well. The PAs don't show really well. Here is the PA of tooth number 3. It doesn't show well, but if you go back and take a look at CT scan, it shows incredibly high detail of how much of loss of bone is there, and if and any canals are missed. There was a question about how do you really diagnose missed canals using the relation techniques. What I typically do is I just go hone on those key. This is the palatal root of number 3. This is the distal buccal root, mesiobuccal root, and we know that the mesiobuccal roots are elongated, slightly the labiolingually or buccopalatally, they will have most of the time a second canal, as opposed to a rounded root, which is DB here. So sometimes there are your hunches. You go back by hunches and say, this must have another canal. And because the way it's anatomically there, it has to have canal. And then you go back and look for the canal, and then you get it. And then you restore the canal, and then it will be followed up periodically. And then a lot of times I get cases, some are medical legal cases, that ask me to review the presence of extruded sealant into the mandibular canal. Now, it's not a big deal in many times because you see the extruded canal. If it is around this canal, it's okay, but in the canal, it causes symptoms. These symptoms could be anywhere from just tingling and some partial numbness to sometimes complete numbness because the nerve gets irritated. There is neuritis. And sometimes they go to the extreme of forming a neuroma as well. And one of the questions asked by the audience was, how do you diagnose, how do you identify mandibular canals if you don't see the cortication well? One of the techniques I always use to use cortical notching. In other words, you take a look at this. This is the implant here in the mandible. And if you look at the lingual border of this, there is a notching of the cortex right here as well. Usually the mandibular canal leaves telltale signs as it goes along the lingual border and crisscrosses to the mandibular foramen. That's where the crisscrossing takes place. And so that's one of the methods. And there are other methods to identify, going back and forth, using all the slices. You have to have all the slices in front of you. That's the only way you can do it. And this patient went through a lot. We went through sinus lifts, buccal grafting, and implant placement and everything else. So I think in these kind of extremely involved cases for implants, you must have a CBCT. Sinus lifts are very commonly done, and it's routinely done, as a matter of fact, to get more bone there and bone back there. And I think we must have a CBCT for all sinus lifts to be able to identify them. And sometimes you see things like this happening, area that is non-healing, and this patient actually came with significant pain in tooth number 3 area here. And then and we had to just tell the look, there's so much happening. There was a graft rejection. This is the graft gone bad, actually, rejected graft. So we had to just start from scratch. And so this is a patient who came in with significant pain on the premolars, which is status post RCT. But again, these things are inert materials. If there's extrusion of material at the apices, they will just stop after a while. And here, when you start looking at canals, you have to use the axial scans, and then start going the axial scans from the coronal to the apical region. Then you will find the incredible detail of the canal morphology, and then you'll be able to correct those missed canals as well. If you don't use CBCT, especially axial scans, you will be hard pressed to identify those anatomical constraints. So see that little gut aperture that is there buccally, that could be irritating the soft tissues here. It has to be within the bony compartment. It can't be outside. And so maybe there's a reason why the patient hasn't been there. And then this is the patient who came in recently, just 2 days ago, actually, a few days ago. Then came with previously there was radiograph taken. This is taken 15th. The large radiolucency in relation to one of the two deep here. And we took a CT scan. It showed significant resorption of the cortical bone bilaterally. And then what seems like a lesion in relation to tooth numbers 22 and 23. But lo and behold, teeth were vital. And this is the case of a fibrosis lesion. There's nothing to do with endo. They were about to do endo on this patient because they weren't sure if there is a partial necrotic pulp and maybe it's somewhat showing vitality. But then after I looked at this case for a while and I said, no, we can't do anything like this. Let's watch in 4 to 6 weeks and look for vitality again. If there's a first sign of non-vitality, we'll change your mind. But this is a classic case of PCD, periapical seminal dysplasia, but not usual. It's usually radiopaque, it's usually mixed density. It usually has a good lining around it. It's got a capsule, but nothing in life is normal sometimes. That's where you have to use your judgment and call. And if you don't use CBCT, especially for placement implants, obviously these implants are out in no time because it didn't really go well. So I think you can use things like Blue Sky Bio, you can use Anatoma, you can use any of those things They're all menu driven nowadays. That means you have special menus. You can import your DICOM data. They will do it for you. They will do the samplemetrics for you. If not, you can do it yourself. And there's also a way to identify, I don't know if anyone saw this, you can identify implants based on a database of radiographs. So it's funny, but that somebody did it actually took time and scanned all the radiographs, all the implants into radiographic format. So when somebody comes and you take a radiograph and you can say, that's an implant that that I want to identify. So that's something just so that our knowledge is there. And painting the canal is another thing that we must do. When you start looking at the mental foramen and the canal, we identify that, and there's a technique called paint the canal, which I'll show in just a second. And we also have to make sure that the occlusal markings are there. This is a very primitive method of using the metal a small wire, the occlusal plane, but that gives you an idea of how much of the space we have to deal with transaconically, and so that we won't go for failures. And then good old traditional gutta percha with dentures that are used as your radiographic stents, they can be converted into surgical stents later on. And then obviously look at the amount of bone available before you place implants, and you clean the canal. So canals could have multiple reformations here. You can actually take a look at how the male foramen has got two different exits. That's part of the loop actually. And then you might have two different accessory foramina, which you have to be careful about, and that might cause some symptoms if you injure that area. Also look at the lingual foramen, lingual nerves, which are right in the middle of the symphysis menti. So lingual nerve, the mental foramen, mental nerve, and the extent of the mental nerve anteriorly. So all those things are important for us, incredibly important. And what we do nowadays is called as either screw retained single crowns and implants or cement retained single crowns and implants. Are very important. You can do either way. But what has changed our game plan is the fact that we're able to scan the intraoral images with high detail and merge them with CBCTs. So if you don't plan it, you'll definitely have lack of anatomical space. So either you go for either bone augmentation or removal of the bone. Now, there's also another technique called chemiography, which is actually used with polyvinyl siloxane placed in the patient's mouth and kind of it mends to the normal anatomy of the patient's face intraorally. And you can actually place the markers on top of it and scan the patient. That way, they're more accurate for abutment reconstructions. And this is the patient which had this chemiography before and had a final prosthesis, implant supported prosthesis for better outcomes. And then you can merge here. You can see the merging of CBCT with CAS. You can actually take the CT of the CAS and then merge the anatomy of the CAS with the CBCT data, so that you can actually plan the implant placement, and you have a beautiful surgical guide. It's all part of surgical guide preparation. Once you have surgical guide, you're good to go. You place implants, sometimes with blindfolded, because everything is taken care of. Today, I'm going to end this last few slides with the concept of what's called as a digital clone. This is going to be a chapter in my textbook that is coming forward in June. Digital clone is nothing but a combination of intraoral scanning, face scans, CBCT, and putting all of them together, integrating into one particular patient. So we don't need the patient for many visits. In the digital scan, you get this incredible detail. This is a scan taken with Direct OmniScan, intraoral scanner, and processed through what's called in-lab software. See the detail, amount of detail, incredibly. Patient's mandibular anatomy, maxillary, and this is the maxillary, this is mandibular anatomy. And then you can put them together virtually. You can, have an occlusion, and then you can plan your vaccine. Vaccine can be done digitally. The cast is created, and then on top of the cast, you digitally wax it, both mandibular and maxilla. You put them together to your satisfaction, and then you actually place the patient's face. So this patient's real face, This patient is scanned at high resolution, and this digitally waxed model actually placed in the patient's anatomy using both CBCT and the facial scans together. So here is how you use this is a software called co-diagnostics. You can merge patient's anatomy, facial scans, intraoral radiographs, intraoral scans, and CBCT together into this particular modality. You can use what are called as markers. Those markers can help you, registration objects, choose how to merge the data together. And then here we are trying to merge them together and trying to identify soft tissues, repeat them for mandible, and then lo and behold, we have entire digital clone. So I think the goal for this technology is that eventually that we all will be doing digital clones one day. We spend less time with the patient, we spend more time digitally, but the accuracy is incredible. That's what we try to gain. Incredible accuracy, and then this is the precursor for surgical guide. And then I have a couple of cases from Dr. Andrew Jivan Kumar, my classmate, who he did incredible work, and he was able to share a couple of cases with me. And especially if your case are dealing with using zygomatic bone and the tuberosity and pterygoid plates, it is a pterygoid implant here placed into the pterygoid plates. And that's a great technique if you don't have bone in the maxillary tuberosity. And then you can actually place it, you can plan it properly, you can do pick-up impressions if you don't want to do everything digitally. And then patient's outcomes are really great. So you can actually place those implants with incredible amount of accuracy. And so CBCT is the go-to technology in those cases. It is the planning for another patient of his with with a pterygoid implant and 2 other implants in the maxillary right. And then lo and behold, they're there, placed with the same accuracy. And then again, mandibular nerve is mapped. And then there was 1 implant placed mesial to it, another 2 implants placed distal to the second premolar. And lo and behold, so we don't have to injure the nerve. And so that's how outcomes are achieved better if you plan properly, if you digitally plan, if you have software like co-diagnostics or in-lab or even Blue Sky Hub, Blue Sky Plan, it helps. And always post-operatively, you can probably use intraoral radiographs. You don't have to use CBCT. Post-implants always intraoral radiographs to help you to kind of look at them and see there's nothing else going on. And then painting the canal is something that you do as part of your treatment plan. Today, there's so many labs available that you can just simply import your data into the structures. So last couple of slides, I want to talk about AI. So AI is coming a big way, and we've published 4 papers in AI right now using deep convolutional neural networks in biomedical engineering. And we have published one in Journal of Endodontics about the artificial intelligence of CBCT aided periapical lesions, and one in the IEEE of North America, where we talked about developing a strategy for anatomically constrained deep learning for automated detection of segmentation and lesions itself. So it's a great information is there. We have a lot of excitement in the air about using the seed technology for AI. And so with that, I want to just end. And I really thank you for your patience. And I know I went many minutes over the allotted time. I'm so sorry, Vivek. I apologize.
No problem. No problem. Thanks a lot, Murli, for your excellent presentation on cone beam CT scan and its applications in dental specialties as well as oral implantology. I'm sure there are some questions from the participants, and I invite Dr. Ramaraju and Dr. Sri Krishna to interact with you and the audience by selecting some relevant questions from the chat box. And Ramaraju, over to you. Thank you once again, Murli.
My pleasure. My pleasure.
Thank you, Dr. Vivek, sir. Sir, it was a stellar lecture indeed. Though the title of the lecture was simple, but you have delved into the depths of the subject. The comments in the chat box go on to say the amazing response your lecture had on the audience.
Thank you.
The participants seem to want more of your knowledge and wisdom, sir. There are a lot of questions, but I'll try to pull up some of them which are related. One participant, Dr. Jatin, wanted to know as to how the CBCT slice thickness can be determined, because unlike an MDCT, a CBCT does not have a post-patient collimator or a pre-detector collimator. So can the slice thickness in the CBCT be modified?
Yes, it's a very good question, and thank you for the question. Again, one of the advantages of CBCT is that we can actually select our slice thickness, which is unlike the MDCT. You can actually select a slice thickness to begin with by selecting the thickness of the voxels. Resolution is the key. So let's say that your resolution is, let's say 200 microns. So 200 microns is like 0.2 millimeters. That's the thickness of the, it's 2 millimeters approximately. So by pre-selecting the resolution, you can select the thickness of each slice, but you can also add the thickness more later on. So sometimes I scan patients at, let's say 100 microns, which is less than a millimeter. But I have the ability to actually add on the layers to make it 1, 2, or 3, or 4 millimeters. So yes, the answer is yes. You can select your thickness of slices, but there's a minimum amount of thickness that you can go for, and beyond that you can't select anymore. But generally, for most of the bone related evaluations, you pick between 1 and 2 millimeters, which is very easy to pick.
Then some questions were related to the soft tissue lesions, sir. Like one participant wanted to know how they could differentiate between a polyp and cyst in the maxillary sinus. And so one participant wanted to know if carotid body tumors could be appreciable in a CBCT scan. And what's the scope of soft tissue resolution in the CBCT machines, which will be coming in the future? So
all three are excellent questions.
Yes.
Please let me answer with the first question. Maxillary sinus cysts are generally larger. They're pseudocysts that are actually filled with fluid most of the time, or mucus. Generally larger, they're most likely sitting on the floor of the maxillary sinus. Polyps are typically, if we're talking about two different polyps, reactive polyps, the non-reactive polyps. The reactive polyps are smaller. They tend to erode the bone underneath. So if you see a small lesion, small polyp on the medial wall of the maxillary sinus, and then trying to erode the bone, those are very reactive polyps. Those should be immediately referred to OMFS or ENT, and then should be removed immediately. There are other polyps, what we call as the general polyps, that are not mucus retention cysts. They actually grow larger in size. They not only grow larger in size, they grow into the nasal fossa, into the nasopharynx. And so these polyps are to be removed immediately. I saw like few cases in my experience in the last few years where the polyps grew into the nasopharynx, and they almost looks like some kind of benign tumors. But when you took a biopsy, they were just polyps. So there are small reactive polyps, large non-reactive polyps, and mucus, rest of them are mucus cysts. Actually. Easy to differentiate on CBCT. Coming to the second question about the identification of carotid body tumors on the on CBCT. Yes, CBCT is a very sensitive technique for identification of the calcification. But along with the carotid body tumors, there will be swelling, enlargement of the carotid vessels itself. But the main drawback is we don't get to see the entire neck. That's the main drawback. We get to see the mandible, we get to see the infrahyoid region a little bit. But what if the carotid tumor is below that? So we can't see it. So unfortunately, yes, we can identify them, but we can't identify them all the time because we don't scan them for that. So naturally, MDCT is better for that. And the third question is, as the technology is advancing, we're trying to cut the radiation dose lower. So as I said before in the lecture, the lower dose is bad news for soft tissues. So the lower the dose, you don't get any soft tissue resolution. So I want to try any soft tissue determinations based only on CBCT. And for that, I think you're better off sending the patient to MDCT with contact. So yeah, sorry, yeah.
There were some questions related to bone density, sir, as to how accurate is CBCT in estimating the bone density, one, and the relation of the Hounsfield units as in CT with the grayscale values in a CBCT.
So it's an interesting question, and thank you for asking. In fact, that was my research last couple of years. I moved on to AI. We looked at CBCT grayscale values. They are not Hounsfield values because we don't have a water bath in CBCT. Unfortunately, difference between MDCT and CBCT is that another difference that on top of the what I told is MDCT uses water bath. That means every day before they scan the patient, they have to put a water bath and measure the zero. And from zero is water level, minus 1,000 is air, and plus 1,000 and above is bone. Unfortunately, we don't have that zero in CBCT because manufacturer said, well, dental practitioners don't need water measurement, soft tissue measurement, so they need bone. So they took out that in grayscale values and calibrated machines just for the bone values, most of them. So if you see soft tissues, it's a gift, but really not meant for that. So I would not really rely completely on CBCT for soft tissue measurements. But if you want to look at the bone measurements, these values, which are, we call them as CBCT Hounsfield units, because there's lack of our better terms, they are actually specific for each machine. And so you can't compare between the machines, unfortunately. My patient has got a 2,000 plus Hounsfield unit. If I click on that, it says 2,000, the bone levels. That is good for that particular patient, for that machine. So if you want to do studies, you can only compare these patients with the same machine, but not two different machines. So all machines are different. So it's kind of unreliable. Now, the second part of the question is that I think the questionnaire wanted to know if it is a bone, it's BMD basically, bone mineral density, not just the density of the bone. So BMD historically has been used, determined by using DEXA scans. So DEXA scans determine the bone density, but unfortunately the CBCTs are not really, you don't have dual scanning technique, you don't have the same kind of measurements. The actual bone density can be verified by clicking on and using a Hounsfield unit, but they are very specific to that particular machine only. So you can compare them with between machines. I hope I answered the questions.
Yes, sir. One participant wanted to know how to reduce the metal artifacts in patients with a metal process during a CBCT scans.
So it's a great question again. It's a wonderful question. I think everyone should know the answer. Only few companies are coming out with a software called MAR, Metal Artifact Reduction Technology. So what it does is, in fact, I'm not a big proponent of that. So I'll tell you why. I see the CT scans coming from the doctors who use the MAR technology, MAR technology. What MAR does is, if anyone use Photoshop and despeckle their images, like we use scanning an old photograph and dust particles are there and that you want to remove the dust particles and you apply this despeckling layer on top of it, they disappear. How they disappear is the important question. They disappear because they increase thickness of the slice. They add slice on top of that. So now I see this metal artifact reduction technology useful in most cases, but sometimes it blurs the images so much that I can't see the normal anatomy. The normal anatomy looks like a really, low resolution to me. So I think it has got good and bad at the same time. I think we should, if there is really bad metal artifacts, you can remove them using MAR technology. The company that does it now is Plan Mecca. The company has it, but all of the companies are really coming up now. The technology that is maybe in a few years, we will see it as a routine click of a button, then there'll be MAR applied on top of it. I would like to see MAR applied on top of the acquisition, not acquiring with MAR. the difference between the two is very critical. If you apply MAR beforehand, it'll mask the anatomy completely. But if you apply MAR after acquisition, which is what I want, but they are not giving me that. So it's a problem at this point. But there is a way to cut down the metal artifacts, but unfortunately at the cost of resolution. So
yes. So one last question from the question and answer box, sir. How do you trace the inferior nerve canal, inferior ulnar canal when it is not visible in the CBCT scan?
It's a very interesting question, and I face this problem all the time myself sometimes. But being a radiologist, I have a few more wounds I've seen. So basically, it becomes a matter of experience sometimes. But I think there are a couple of techniques. One technique is the cortical notching. So we know that if you look at axial scans, we know that from the lingula, the canal runs parallel to the lingual cortex. At the first molar region, just after first molar, it crosses back and goes to the buccal cortex. So we know how the mandibular nerve runs anatomically. So I expect mandibular in that particular region. It's lingual, the mesial to the first molar, and then it goes into the buccal, the mandibular foramen. So having that knowledge in back of my mind, I go through repeatedly these areas because none of the software will help you. Software only asks you to pick points of interest. If you don't know the points of interest, we can't help. But I think it's a matter of knowing anatomy and using some small tricks like cortical notching, because the mandibular nerve notches the lingual cortex and then notches the buccal cortex. So look for the notching techniques where the thickness of the cortex becomes slightly reduced, and then it becomes irregular, almost like scalloping. That's one technique. Of course, it doesn't work all the time. And the second technique is how do you look at these in patients with osteoporosis? Osteoporosis takes away the cortical borders. And unfortunately, it is a matter of just knowing the anatomy well. And sometimes I go increase and decrease contrast, increase, decrease densities, and increase, decrease of brightness and contrast. So we call it gamma. Gamma is a combination of the contrast and brightness. Sometimes you get to pick them up, pick the areas of interest that way. But there is no real scientific way to identify those things other than your knowledge of anatomy, your hunch, your experience.
Thank you. Question and answer session. I now hand over the proceedings to Dr. Ramaraju, sir.
Yeah, thank you, Murali sir, for your excellent presentation. I don't have many questions because I think all of you have answered all the questions which were came to us before the presentation. And thank you for the motivating for all the oral medicine resident specialists to do more and more work in this aspect. I have one or two personal questions, sir, actually. Is there any studies including contrast medium into the CBCT to enhance the soft tissue? That is one thing, sir. And any parameter changes in the CBCT machine before exposing to reduce the metal artifacts?
So the excellent questions. Actually, I have tried many different methods to figure out that how to reduce the KV and how to reduce MA. One of the things I've done is play with voltage. Some of the machines are actually so determined that you can change KV and MA, but it's just a matter of picking the right size of the volume, because if you go from a large volume to a small volume, two things happen. One is obviously you get more contrast and you get more focused, but you also increase the noise. Noise increasing goes up really high. So I have noted in my experience that the only way you can reduce metal artifacts is trying not to focus the area of that metal within the volume of interest. We call the FOV, as you know. The FOV can be adjusted so that you eliminate the metal and then try to focus mostly on the non-metal areas. So let's say that if you want to get the root apices, you don't need the crown. I would limit my field of view to only up to the, let's say, CEJ or even a little beyond that. That way you don't have to worry about the metal artifacts. The good news with metal artifacts is that they only come across in the area of interest where they go horizontally. They don't go in different ways, which is a good thing. So by you can crop it off completely before you start diagnosing the anatomical variation. But again, it's something that we all struggle with, and I don't have a correct answer for that. But there are no real good parameters to definitely tell the listeners to follow, because it could change from machine to machine. Some machines are incredibly easy to operate and they can change AV per MA. Some machines don't. And but again, it's selected based on your need. But I think focusing on the field of view is the best way to go by.
Thank you, sir. I think this is the end of the questions.
May I invite Dr. Gampa Ravinder sir to give a message. He's joined us from USA.
Respected Principal Dr. Ramchandra Reddy Garu, dental faculty, colleagues, alumni, and students, Dr. Muralidhar Mupparapu has delivered an excellent presentation on the role of CBCT in dental practice. As a general dental practitioner, I had opportunity to utilize CBCT for a couple of years, and Dr. Muralidhar Mupparapu has given me his valuable opinion on several of my CBCT findings. And as he said, I requested report for implant placement and planning, and there were several incidental findings which I did not realize. As he said, CBCT has a major role in day-to-day general dental practice. And he has covered almost all the areas where CBCT can be used. The major consideration is cost of the CBCT machine. I had one in the past. It was like a white elephant. And I know Dr. Mel may be a little upset if I say that, but it has its own use. Maybe if the cost comes down a lot, which has drastically reduced in the recent years, it can be utilized by many dentists. And I think if it is not affordable to have a CBCT in each and every practice, somebody, some entrepreneur can start a mobile CBCT.
So now we have CBCT is available all over India, most of the dental institutions and some of the clinics also. May I invite our teacher, Dr. Ramchandra Reddy sir, also to say a few words.
Thank you, Ravinder.
Thank you.
Hello, everyone. I'm very happy to be here, Murali. Our distinguished alumni is occupying a very prestigious position in a Ivy League university.
Thank you, sir.
Talk you gave was very extensive about the cone beam technology. You explained how the technology works, the physical, the radio, physical aspects of it, and also the applications in dentistry. It looks like the CBCT is applicable in all the specialties of dentistry. Maybe in certain specialties it is more applicable, like surgical specialty, and particularly the deep-seated lesions and the new thing like the implantology, which is the craze of dentistry in India now. Everybody wants implants to be done. Only the cost factor is keeping them away. Similarly, CBCT also is expensive. Otherwise, many of people would like to have it here, provided the volume of patients they get is more. I don't think it can be solved that easily. just like Ravinder was telling that he had a CBCT on wheels, but it did not click, I believe, in his. And I don't know whether it will work in Hyderabad. Vivek and his friends must think about it and then plan so that more people could use this technology. It's a wonderful technology and certainly a great improvement. We appreciate, I enjoyed the evening, the lecture. More than that, looking at all of you, the alumni, I'm really thrilled and happy.
Thank you, sir.
Thank you.
Thanks a lot for your blessings. Thank you, Dr. Gampa Ravinder, sir, also. May I invite Dr. Ram Basani to propose vote of thanks as we are running out of time.
Yes, sir. Well, that was an awesome webinar session, and I think we're all like it was like a fast charge of our brains, and that was an excellent learning experience to all of us. Let me proceed with the vote of thanks now. First of all, I would like to thank the keynote speaker of today's session, Professor Muralidhar sir, for his excellent lecture and for spending time with us this Sunday. Sir, thank you so much for that lecture, for enlightening us with your fantabulous presentation and inspiring us with sharing your vast expertise and experience in this subject. So we are also so happy and so lucky that you're alumni of GDCH Hyderabad. Next, I'd like to thank all the audience that were logged in today, especially the ones who are submitted their questions and made the presentation interactive. Next, I would like to thank the moderators of today's session, Dr. Ramaraju sir and Sri Krishna sir, for their for so adeptly organizing this session, for moderating this session, and making it a very interactive and lively session. Then I'd like to thank the senior members, the senior alumni of GDCH, Dr. Ramchandra Reddy sir and Dr. Ravindra Gampa sir for their valuable suggestions. Then I'd like to thank the president of the Alumni Association of GDCH Hyderabad, Dr. G. Chandrasekhar sir, for his constant support throughout these webinars. And he's been also the observer of the Telangana State Dental Council for these webinar sessions. And I'd like to thank the convener of the Scientific Committee of Alumni Association of GDCH, Dr. Vivek Reddy sir. Without sir, you all know that these things would not be possible so well. Thank you, sir, for being so for the push and for being so captious and making things for bringing out the best of all of us. And not the least, I'd like to thank Gagan, Mr. Gagan, Ms. Vanita, and Vamshi of the WOW team. They've been constantly working in the background and constantly supporting us with this alumni relationships. And let me also take the opportunity to let you know the coming up seminar, the webinar that's coming up in the next month, that is 16th May, Sunday, 16th May, 2021. The topic is Beyond Current Dentistry, Facial Aesthetics by Dental Practitioners. It's by Dr. Ben C. Ng, and he's an alumni of GDCH and he's presently at Malaysia. He has his extensive training in facial aesthetics from USA, and he's been practicing facial aesthetics for over 7 years there, and he'll be presenting this webinar. The webinar is aimed to generate the awareness of dentists on the treatment modalities incorporated into their daily practice and to acknowledge the expertise of dentists stand on facial aesthetics. I hope all the audience would again register and be present for the coming up webinar. Thank you.
Thank you, Ram. May I invite Dr. Chandrasekhar, our beloved president of Alumni Association, to give his concluding remarks.
Thank you. Thank you, Dr. Murli, for the extensive lecture, and I acknowledge the presence of many senior members, Dr. Anil Kumar Grover, Dr. N.S. Yadav, Dr. Akshay Gupta from Jammu, Dr. J.N. Rao, Vijay Srinivas, Murli Mohan, Dr. Nagalakshmi, Mahesh, Dr. Sharada, Dr. J. Kranti, Dr. Jeevan Kumar, Dr. Ratolikar, Dr. Jayendra Reddy from USA, Dr. Prasad Mandava, Dr. Venugopal, Dr. Preeti Chitgopar from USA, Dr. Rekarani, Dr. Sarjeev Singh Yadav, and Dr. Shiv Kumar. Hope all of you enjoyed the lecture, and if you have any doubts, you can mail him on mmd@upenn.edu. Thank you for your lecture, Murli, and look forward for more in the future. Thank you one and all for the active participation of today's webinar. Thank you.
Thank you.
Thank you.
See you next
Thank you all.
month.
Thanks.
Have a good evening and good day to Dr. Murli in US and others from abroad.
Thank you.
Thank you.
Thank
Bye-bye
you.
now.
Thank you all. Thank you all. See you next time.